for about 25 minutes plus a few minutes for questions following them. And the first speaker, very pleased to welcome Ganna Rozhnova. Ganna is assistant professor at the University Medical Center in Utrecht. Her research centers on the application of infectious disease modeling to answer questions and to support evidence-based policy, public health policy for HIV, SARS-CoV-2, influenza, CMV, and childhood infections. So welcome, Ganna. Would you like to continue?
Good afternoon, everybody. Thank you, Valerie, very much for the introduction and also for the invitation to present here. I would also like to thank to Claire Bonner and Claire Merritt for organizing the meeting. So my talk will be about controlling the pandemic during the SARS-CoV-2 vaccination rollout. And I think it's a population level talk, and the next speaker, Yasmina, I guess she will be presenting something similar, but for the UK. My application is done for Portugal, and most of the work has been performed by João Viana. He is a student at the University of Lisbon, but there are a number of collaborators from the Netherlands and from Portugal who have contributed on this talk. You can see all of them here. And I'm very happy that we have Manuel Gomes on our team. He's he's a member of the COVID-19 vaccination committee in Portugal, and he's one of the main advisors also for the COVID-19 pandemic in Portugal. And partially because of that, also the project was supported by the Ministry of Health of Portugal. The project had also the support from the Portuguese Foundation for Science and Technology. So the results I will present, they have been submitted to Nature Communications, and by what it looks, they might be published quite soon. There is also a preprint available on Research Square, and in the spirit of open science, we share all our codes and everything on GitHub, so you can check it out if you're interested. And because of the importance of this topic, also this research got quite a lot of attention in the Portuguese media, on TV, in the newspapers, and everywhere. So let me tell you just the background. We all know a lot about COVID, but what regarding Portugal? So we had in Portugal 3 waves of COVID-19. The vaccination started, as in most countries, at the end of December 2020. And the government, let's say, still continues to struggle to choose the right mix of measures to keep COVID-19 under control. So the objectives of this study, we look mainly at 3 research questions. The first question is, what will be the impact of vaccination on transmission dynamics in the COVID-19 in Portugal? Most importantly, when and which control measures can be relaxed as the vaccination is rolled out in 2021. So that's the most important question. When will we return to normality? And I have also added a question at how these predictions would be affected if the vaccine efficacy was reduced to antigenic escape variants. Of course, we are not the only one who are looking at these questions, and I have listed here just 2 references. One is by Professor Matt Killen and his collaborators. It's a study for the UK that addresses similar questions, was published in Lancet Infectious Diseases. And of course, there was also a report by the Scientific Advisory Group for Emergencies, published in mid-February. And there are other studies, let's say, that we cite, but if you are doing something similar, I would welcome contacting me and telling me what you're doing. So I'm interested to include it also as a reference if it's relevant. And I'm a modeler, so we built a model, a transmission model to address our research questions. The model has susceptible, exposed, infected, recovered structure. As you can see, we divide the people who recover after infection in 2 compartments, those who were not hospitalized after infection, so those who were asymptomatic or had mild symptoms, and those who were hospitalized and registered. And then the model is age structured, so the age structured parameters are susceptibility to infection, forces of infection, and hospitalization rates. And then on top of this, so that's nothing fancy, let's say, on top of this, we also include the vaccination. And vaccination, as the current policy suggests so the vaccination should not discriminate among the disease status of individuals. So all those who are not infectious at the moment should be vaccinated. And this is shown as these arrows were susceptible and exposed. They all go to the respective vaccinated compartments. After the hospitalization or recovery, people can also be vaccinated. And the properties of the vaccine that we are looking at. So first of all, the vaccine is an infection blocking vaccine, and this is implemented as reduction in susceptibility to infection of vaccinated susceptible individuals, as shown here. Then the second property of vaccine is that the vaccine efficacy in infectivity might be reduced, and this is not shown but in the diagram, but it means that the infectivity of vaccinated individuals might be lower than the infectivity of naively infected individuals. And then, of course, the vaccine efficacy, there is vaccine efficacy in reducing the probability of hospitalization and death, which is shown here as the reduction in the hospitalization rate. And these efficacies, they are, let's say, we parameterize the model using what is known currently based on the vaccine efficacies and vaccine effectiveness in real world studies for against infection, against disease, and against severe disease. So there are 10 age classes in the model. Overall, we have broader groups for susceptibility classes, and we have 5 seroprevalence classes. So the model is it involves a lot of different data sets, like the demographic data set, for example, but it's formally fitted only to 2 data sets. So the observation model includes, is based on the age stratified hospital admission data, and we have around 28,500 hospitalizations for almost a year, starting from the first official case on the 2nd of March. And then we estimate the number of infectious individuals 5 days prior to this official case on the 26th of February. And then we also incorporate age stratified serological data after the first pandemic wave. And the fitting is done in a Bayesian framework using STAN. Overall, we estimate like 32 parameters, which is a shocking number when I counted, but if you think that hospitalization rates are estimated for 10 age groups, you're left with 22 numbers and so on. And the method works really well, I think. And the whole methodology was developed before in a prior publication that I had with all the collaborators in Utrecht, which was published in Nature Communications and addressed, looked at the model-based evaluation of school and non-school related measures in the Netherlands. The only thing that this was done only for the first pandemic wave, and now it's extended to include different periods. I will stop, or will explain a little bit in detail what I think we do well from my point of view as a modeler, what we do maybe a bit differently from the rest of the community, or I think what is a nice feature of our work. So we implement, as many people, we implement the contact patterns for the population. For the pre-pandemic contact patterns, we use the study by Alessandro Vespignani and his collaborators, which was published in 2021. It's a Portuguese-specific contact matrix. And I don't know whether you know what this contact matrices mean, but basically you can look at what is the age of a participant and what is the age of his contacts, and then you see how many contacts per day these people have. And for example, for the, as you can see, for the age groups of 10 to 20, there are on average 8 contacts per day, because of course these are children and at school they make many contacts. So on average, before the pandemic, there were 12 contacts per day for an individual in the population. And then we use also matrix developed by Jantine Bakker from the Netherlands for the, not developed, but she deduced this matrix based on the survey data, which was collected in the Netherlands after the first pandemic wave. And based on that, we infer how this matrix would look like for Portugal. And here's the matrix, and there would be on average of the first pandemic wave, there would be 5 contacts or something like that. And what are the features of this is that before the pandemic, if you look at the average number of contacts for a person of a given age, so the biggest number of contacts would be for school children, and then there would be smaller for all the age groups. But after the first lockdown, what we see is that the contacts were reduced, and especially in the younger age group to a big extent, and much smaller they were reduced in the older age groups, because the schools were closed, of course, and all the individuals, they already have mainly essential contacts. So what we do then, we assume that this transition from before to after the lockdown, that it's a smooth transition, and we model this as the contact rate as a linear combination of contact rates before the lockdown, shown as here. BKL is the contact rate of age group K with age group L, and AKL is the contact rate after the lockdown between these two age groups. So we model it as a linear combination of the two matrices with coefficients, which is 1 minus F and F, where F is just a logistic function. And here is an example of this. For example, it's a red is a logistic function, which goes from 0 to 1. And it's described by two parameters. And the first parameter is where is the middle point of the logistic function. And the second parameter is how steep it is. And these parameters, they have a meaning. It means that how quickly the measures, the control measures are introduced, and what is the average timing of measures. So in our fitting procedure, we estimate all these parameters. And this is the median, for example, trajectory. It's an example, it's not, it's an example of the median trajectory, and these are individual trajectories. And we do this for the whole, period from March 2020 until February 2021. And we have 5 such periods. So the introduction of the first lockdown, when the first state of emergency was announced. Then after the wave was controlled, so there was a relaxation of measures at the end of May, we estimate that. Then in summer, basically not much happened. And after that, the schools opened, and there was this further relaxation due to school opening and changing the contact patterns in the rest of the population. And this launched kind of a second wave. And then there was a second emergency state announced. So the cases, well, sometime after the cases started to decline, and due to relaxation because of Christmas and new holidays, there was a fifth period. So here's how this fit looks like. So you can see on the y-axis, you can see daily hospitalizations in different age groups, starting from the younger 0 to 20 until 80 plus. So the best is seen where you have a lot of hospitalizations, and this is the whole time frame. So you have the first wave, you have low activity, then you have like school opening, and then in the beginning of September, it starts to increase. So this is the second wave, was slightly curbed. Then there is a new year, further relaxation, and then the third wave started. We also fit this formally to the seroprevalence data. And the seroprevalence data is shown here as these error bars. And the dots was the error bars, and the shapes, the violent shapes, are actually our predictions from the model, the distribution from the model. There was not much difference after the first wave in terms of the seroprevalence. We estimate something like between 1.8% for young children, and 4 to 6% for 20 to 40-year-old individuals. And then we estimate how the seroprevalence would also change, and it would reach roughly 19% by 15th of January in the model. And what we do also, so this is a repetition, so we estimate the whole time varying contact patterns in the population and RE of T. So that's the total hospitalizations, which I already showed. The green lines show the transition points between these different periods that we estimate. And this is how the average contact rate changed in the population. So it started from the pre-pandemic level of 12 contacts, and it drops a lot. Then after some of the measures were relaxed, it increases slightly. This is, I call summer level 2020, and then it increases again in autumn due to school opening that went back, and so on. And we also estimate the RE. So if you are a modeler, you know, so the RE is calculated actually taking into account both how the contact structure in the population at a given moment, but also the estimated level of seroprevalence in the population. And then it starts above 2 actually, and then it went to roughly 0.65 if I'm not mistaken during the first lockdown. It stayed barely below 1 during summer, went up, and so on. And I will be talking, because we look at the relaxation of measures, I will be looking at when this effective reproduction number becomes smaller than 1, because that's what is the relevant measure. And it can happen in 2 cases. First, you can have measures in place, as it happens now in many countries. So, and I call you have control, but it's like partial control. And ideally what we want to have is that you have RE smaller than 1, but also your pre-pandemic, the contacts have returned to pre-pandemic level. So that's the vaccination. This is the vaccination program that we use in our model. We implement the plan that was accepted or developed by the Ministry of Health before vaccination started on 27th of December. As in many countries, this vaccination program involves several phases. So there are 3 phases, and there are different groups of individuals who are vaccinated in the different phases, like healthcare workers or long-term care facilities, residents and staff. And there are also risk groups which are defined based on morbidities, in the population in the phase 1 and phase 2. And the plan assumes that the whole population of Portugal will be vaccinated, 10.8 million individuals, until the end of 2021. And in our analysis, we assume, well, we make certain changes. For example, we assume that the maximum vaccination coverage is 90%. It's actually very high, but Portugal is a country where individuals also seem to listen to the advice of the government, and the intent to get vaccinated is high. It was shown to be like around 95%. We also assume that children under 20 are not going to be vaccinated in 2021. So analyses are based on the vaccine efficacies for the Pfizer vaccine. And we do that because most of the distributed vaccines, at least at the moment when the study was submitted, they were by Pfizer, so 96% of total doses, and only 2% of doses were by AstraZeneca vaccine and 2% were by Moderna vaccine. As I said, the vaccine has infection blocking properties. Also, vaccination is a simplified event, so it's a single event in which you get a kind of protection equivalent to vaccine doses. And in our analysis, we consider 2 sets of vaccine efficacies, or let's say pessimistic and optimistic assumptions about the vaccine efficacies. As much as we could, we used the information already from the literature, but the main difference is, of course, is well, all vaccines showed very high efficacy against disease, but the question is how much they prevent transmission. So these 2 sets, they're distinguished either by high or low efficacy in reducing susceptibility. And also there are 2, in our analysis, we assume that there can be either behavior change in vaccinated persons or no behavior change. So you might imagine that vaccinated persons just want to increase their contact rates to the pre-pandemic level as soon as they are vaccinated. So we use, so as I said, morbidities in the vaccination plan, they are defined by ICPC2 codes. So these are codes relevant in, in medical practice. And we use data on the age distribution of these morbidities in the population from the Portuguese Ministry of Health. So here you see the different risk groups that are relevant for the vaccination. And this is the proportion of population in a given age group, so with a certain morbidity. So we implement all of this information and we calculate what actual vaccination rate will be in the population. And it's shown here on the right side. So vaccination rate is just the number of people vaccinated per day in the population, and shown as a black solid line here. And in color, we show the proportions that are attributable to vaccination of individuals who are older than 60 years old or between 20 to 60 years old. And you see that in the beginning, there is a vaccination rate is quite low, but then it's expected to increase slightly. And then in the beginning, it's mainly, actually it's 50 to 50 maybe ratio of vaccination of older individuals and younger individuals, because, for example, at the same time in long-term care facilities, both residents but the workers also vaccinated. And then we calculate what the vaccination coverage would be in the population, the age-dependent vaccination coverage and how it would increase. And again, the vaccination coverage of 90% would be reached for the older age groups like 80 plus, and only in mid-November somewhere the group of 20 to 50-year-olds would be completely vaccinated. And this is the total projected vaccination coverage in the population. And so by May 1st, it should be reached like 9% of the population, and then 38% by 1st of August. And then at the end, it would be 73%. And the actual data, I also plot the actual data for the vaccination with first and second dose. Unfortunately, it's not going much faster than, well, you would think that maybe somehow it will be, you know, the vaccination coverage would increase faster than projected, but it's not. So it's increasing a bit faster for the first dose because there is intention to give the first dose to more individuals and delay the second dose. But it's overall still going as it was projected. And then the relaxation scenarios, we have 4. So lifting all measures or partial lifting of measures as in autumn 2020. Lifting of measures is in summer 2020, and stepwise relaxation of measures. So I will start, this is the most dense slide that I have with a lot of information. I will try to walk you through. So in the first column, you have scenario 1, which is relaxation, complete relaxation of measures. So you have the average contact rate, which is shown here. This is the blue line when this relaxation happens, and you go to normal life immediately. And what you see is that this leads to a very large wave of hospitalizations, so roughly almost 60,000 hospitalizations, so the median value. And the RE value would increase, well, from the value below 1 to almost the value at the beginning of the pandemic, which is around 2 point something. And then it would, almost at the peak, it would reach 1. So that's, let's say, the point when we reach control, and would be roughly in the 3rd week of May. And yeah, and then basically it would be done. The problem was this, of course, that this scenario is not desired at all, because the hospital capacity would be exceeded by several times. And in this scenario, 60% of the population would gain protection in the population through natural infection, and only 10% through the vaccination. In the scenario 2, we relax the contact rates to the level of autumn 2020. So we kind of open schools, and we see that there would be a small a relatively small still outbreak, which could be comparable to the first wave. And the control would be, so RE would also increase above 1, and the partial control would be reached on the 29th of June 2021. And in the third case, which is relaxing measures as in summer 2020, so there is no outbreak at all, because I mean, it's logic, because there was no outbreak also last year. Why would be the outbreak this year if we do exactly the same? And the RE doesn't even increase to the level of 1, but the measures have to be kept in place to prevent further transmission until enough people are vaccinated. And in the last, so in the scenario 1, when we have the stepwise relaxation, what happens is that we increase the contact travel rate first from the lockdown till the level of summer, then till the level of autumn, and then till the pre-pandemic level. And I have chosen just 3 timings of these different interventions. And as you can see, the epidemic activity, what I say, can be low. So the number of hospitalizations would be comparable to the past year. Interestingly also, that RE would still increase above 1. And what it means that there would be still circulation of the virus, which you could see in the new cases, but the number of hospitalizations would be relatively low in the population. Because all the vulnerable groups have been vaccinated already by that point. And the full control, so when you go to pre-pandemic contact levels and already RE below 1, would be in the beginning of 2022 reached. 36, by that it's 36% would have acquired immunity through the natural infection, and 48 through the vaccination. Now, what if it's important? So this timings in this scenario, I have chosen such that there is really no outbreak. But what's interesting, if you switch just this third step, so going completely to pre-pandemic life to 1st of October to 1st of August, let's say, you can still see a large outbreak at the end of the year. And this is because it would cause an increase in hospitalizations in much younger age groups where not all people have been vaccinated yet.
Ganna, can I ask you to wind up quickly so that we have a little bit of time for questions, please?
Okay. Yeah, so I will say just a few things. So if you have pessimistic assumptions about the vaccine efficacy, the things get much worse. So there can be a much higher probability of outbreak at the end of 2021, as shown here. And of course, if there is a behavior compensation in vaccinated individuals, it also makes things very different, and there could be like 2 outbreaks. And then there are a few limitations. I will just say main ones, probably, well, first of all, there is no waning of sterilizing immunity in the model. Unlike in some other works, there is no seasonality, and the selective advantage is not estimated. It's put in based on the UK data and transmissibility of the UK variant. So I think the conclusions is that, well, there can be the quick relaxation can lead to new waves, and there will be a lot of measures necessary. And the best scenarios probably are a gradual relaxation of measures until the end of 2021. And if possible, of course, you need to increase the vaccination rate. But for Portugal, that's at the moment not happening. So I think I'm done. So please go ahead with the questions.
Thank you very much. So there are 3 in the chat at the moment in the Q&A. The first one was to do with the information content of the 10 age class model relative to the simpler models, and a question from Jamie Wood as to whether you had assessed that.
What do you mean information content? So whether I tried whether this model can be behave in the same way as a model with 1 compartment?
I would guess so, and we probably haven't got time to go over to try and ask Jamie that. But I guess you need the age class model when you come to, well, it depends on the vaccination strategy.
The value of this model, I think, is that it introduces a lot of detail, realistic detail about the vaccination program. So, and for that, I need the age classes, and I also want to be able how the age dependent transmission occurs in the population and so on. So, yeah, unfortunately, in this case, it was not possible to use a simple model.
Sure. Tom Britton asks about why you assumed that the 80+ age group are only finishing vaccination by the end of June, and commenting that most EU countries, he thinks, have now already vaccinated all over 80s.
Well, I used the program that was developed before the vaccination started. And that program was not based on vaccination only of age, but also of these different morbidities. And in 80+ age group, you don't have all the morbidities that were identified in the vaccination plan. It's only in the 2nd phase of the vaccination program, which states that all individuals above 65 years of age need to be vaccinated. And that was not, yeah, it didn't have a deadline, which is now. So I don't know, I could ask Manuel whether this already happened, but according to the plan, it was not happening, yeah.
Okay. And the 3rd question from Andre, thanking you for a nice talk, and asking, is it correct that reinfection is not a part of the current model? How important would it be to include it, especially for young individuals with higher rate of asymptomatic or subclinical infection, and in regarding to the vaccination program?
I think overall, of course, including the reinfection is very important, but I see it's more important for looking at how transmission to endemicity will happen and what will happen in the future dynamics. I think the reinfection overall, for at least for hospitalizations, it should be less relevant, because the belief is that if you had the infection once, you will not have again the severe infection again, so you will not be hospitalized. So Of course, these people they will contribute to transmission, but they will not contribute that much to hospitalizations at what we are looking. And this is actually something that we are also looking and developing further. But we need more data, let's say, to fit the model formally. We need more data on the reinfection rates in the population and how they are age-dependent reinfection rates and so on.
Okay, thank you very much. And that's perfectly timing.